Dr. Sandra Japuntich. I'm the PI of the FreSH study. I want to thank you all for being here, and I want to thank you all for being part of the FreSH study. As you know, the practitioners are the lifeblood of the National Dental Practice-Based Research Network, and we really appreciate your contributions to the network as well as to science and to improving dental practice. This is a meeting for you to talk about, to meet and greet each other and also talk about how things are going and get some help with problem solving and sharing best practices with each other and help from us if that is helpful. So can we have the next slide, please? So like I said, when we started, I'm going to give some brief study announcements for FreSH, and then we're going to hear from Dr. Carpenter and a panel of people who've been doing well with FreSH recruitment, and then we'll have time for sharing and question and answer. So just a study progress update. These were the numbers as of last week. We had 283 participants. We've actually passed 300 this week. I think we're at 307. We have 40 practices participating, which includes 52 practitioners. But we're still recruiting practices, so please tell your friends if you like what you're doing. As you know, the benefits of participating in the FreSH study are learning how to intervene with tobacco use and getting a lot of practice, earning CE credits for events like this one, giving things to your patients. You get to keep the study iPad, or your practice does, and then collaborating with other oral health practitioners and having sort of a community of practice. I also want to announce, you may have seen the email, that we upped the practitioner payments to $100 of participants, and now you can make up to $2,400 per practice for recruiting, and then some of you will participate in an interview as well. So with that, I want to welcome Dr. Carpenter. He is a co-investigator on the FreSH study. He's a professor in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. His research is focused on tobacco control, smoking cessation, nicotine dependence, cancer prevention and control, and behavioral medicine. He is also a clinical psychologist like me. And this, I think, is your first foray into the dental setting. Right, Dr. Carpenter?
It is. So don't hold it against us that we are clinical psychologists. So thank you, Sandra, for that invitation or that introduction. I'm delighted to be here. I've actually been looking forward to this for a couple of weeks now. It's we put this on the calendar some time ago, but I've looked ahead to this, and I just think that it's so important that we're doing this, and I hope we just generate some ideas, some excitement, some enthusiasm, and if we haven't done so, then we have failed. So I'm going to talk about medication sampling. I'm really talking about NRT sampling. For those of you who don't know that acronym, it's nicotine replacement therapy, NRT. You think of patches, lozenges, and gums and things like that. That's nicotine replacement therapy. So what this really is about is reaching people who smoke where they're at. And sorry for the pun here, but literally and metaphorically, we're trying to reach people out, both in terms of their motivation to quit, which may be lacking, may be ambivalent, and obviously we want to reach them where they're at physically, because I think gone are the days of asking people to come to a certain place and ask and to engage in a sustained cessation program. I think we really have to go out to where they are, and that includes the dental settings. So if I had a longer venue for this, I would go into each of these in detail. But these 5 things, these 5 problems, are the 5 things that guide my research program and really the whole impetus for why we're here tonight. Again, I would show you data on all these. I'm going to ask you to take it on faith that these are true, that yes, there are guidelines that say you have to ask, advise, refer, and things like that, 5As, 5Rs. Many providers are doing that, but they're asking, but there's some not always advising, and then beyond that, it's very inconsistent. And as you well know, we all know that many people are either unable or unwilling to quit. They've tried and tried and tried. They're frustrated. They don't know what to do. A lot of folks have misperceptions against evidence-based treatment. I'm going to get addicted to the nicotine patch. It causes a heart attack if I smoke at the same time. It was developed under some nefarious conditions, and I don't trust it. there's been oodles of qualitative research to dig into the misperceptions that people have against evidence-based treatment. So, and not surprisingly, use of evidence-based methods to quit smoking is abysmally low. Okay, your definition of abysmal and mine may not be the same, but I'll put it to you at around 25% of people who are trying to quit smoking. Okay, not the entire population of people who smoke, but people who are making a quit attempt, about 25, maybe 30% will use an evidence-based treatment. Most people are using nothing, or using something incorrectly, or something else, or something that is, I'll say, completely not evidence-based at all. And I am a firm believer that words don't always work. We can advise and counsel and suggest and cajole and urge and do all we want to ask people who smoke to quit, but words don't always work. And I'm a believer that we need to be thinking beyond sort of advice giving, for lack of a better phrase. And let's also face it that a lot of treatments that we have existing don't lend themselves to practical settings. You have all limited time with your patients. So if I were to come to you with a intensive smoking cessation program, or Sandra would do so, you would, shut the door in our face, rightfully so, because those things just don't lend themselves to practical settings. Okay, so what do? Pragmatism. Pragmatism, simpler can be better. Okay, what does pragmatic mean to me? If you've ever read a researcher by the name of Russell Glasgow, he is well known in this field for pragmatic interventions. And you can read all kinds of things that he would suggest are what's pragmatic. But what does it mean to me? And I think this is sort of face valid. First off, it's got to be brief. If I'm suggesting a 3-hour intervention, again, you should shut the door in my face. I'm a firm believer that we should not deliver nor offer treatments to people who want to quit. Think about it. Say, Mrs. Jones, do you want to quit smoking? Yes. That's great. Okay, I've got something for you. But why do we ask it that way? Why do we ask if you want to quit smoking and then I'm going to offer something? We don't do that for diabetes. We don't do that for any other behavioral health condition. So I think active treatment for everybody. I think pragmatic has got to be no extensive training, no complicated instructions. It's got to make sense to you. It's got to make sense to the person receiving it. And I'm not to dismiss intensive treatments. They are better in terms of efficacy. I don't doubt that. But I'm willing to sacrifice some efficacy if it means I'm going to reach more people. Because at the end of the day, the impact of any intervention is a function of how strong it is, efficacy, and how many people you can touch with it, reach. Okay? Impact equals efficacy times reach, and we're going to focus on reach. Not to altogether ignore efficacy. Okay, medication sampling. What is it? It's exactly what it sounds like. Bingo. It just hit the face valid criteria. Okay? I almost don't need it to explain it to you. You know exactly what it is just by those two words. It's providing a sample of a product, in this case, nicotine replacement therapy, NRT, broadly given with minimal instructions without any firm commitment to quit. Okay? So right off the bat, we're changing the paradigm here. And we're not saying, you want to quit smoking? Yes. Okay, this is what you got to do. Okay, boom, 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 boom. This is sort of a liberal delivery of evidence-based treatments, as liberal as it can be, possible, quite likely. And we've used all kinds of metaphors before, and we could probably think of a few others. But you get the sense that you're just test driving it. Let's just test it out. We know you've tried this in the past. It may or may not have worked for you. You're still smoking, so clearly it did not. But maybe there's a way that we can learn upon that, and let's build upon that. So maybe medication sampling is a pragmatic option for delivery in busy clinical practices. So just to convey a little bit about me, I've been doing this for over 10 years. And here's just a few of our studies that have done some variation of the things I'm talking about. Actually, we have another one ongoing. It's this one in particular that leads us to tonight. It is not a made-up statement that the idea for this came in the dentist chair for me. I'm not joking when I say that. Okay, so you all did do this so well. When a patient is in your room, what do you do at the end of the day? You get them a bag. What's in the bag? Toothbrush, toothpaste, floss, etc., etc. Now, I understand that's partially marketing. I get that, but it's also about oral health, right? And it doesn't require a lot of instruction, doesn't require a lot of time. Everybody gets it, okay? So I decided to do it in primary care. It just was I don't know if it was lower hanging fruit for us, but it was a trial that we did in primary care. Sandra came to me, and I applaud her for doing so. She had access to this network, and I thought, wow, this is a great idea. Sign me up. So that's how the FreSH study was born. So I'm going to talk a little bit about that tip-top trial. Okay, this is the primary care medication sampling. We love our acronyms in my end of the street. Tobacco intervention in primary care, treatment opportunities for providers. Say that 3 times fast. This was a cluster randomized trial, exactly like FreSH. Okay, we randomized not participants, not providers, we randomized clinics. So this was 22 clinics across the state of South Carolina, who half of them, all participants in all clinics were given bags. That bag included cessation advice, referrals to the quit line, those types of things. Brochures. For half the clinics, for half the participants, we also put in a 2-week supply of both nicotine patch and lozenge. And I can get into the rationale of why, but I don't think it's critical right now. We recruited 1,245 participants, and everything was done by the clinic staff. We did not have a single research staff member present in any of these 22 clinics. We did give everybody, an hour and a half overview at the outset of the study. I think something's done similarly in FreSH. And we told everybody, hey, deliver cessation advice as you normally do. If that's a 5-minute thing, do it. If that's a 10-minute thing, do it. We're not going to script this for you, okay? All we're going to do is just give you a bag to hand out along the way. So the baggies were given out that either did or did not have NRT along the way. Very similar to FreSH. Okay, outcomes. So from left to right, we have quit attempts within the first month. Now, mind you, we only gave 2 weeks of NRT. We gave 2 weeks of NRT. Any quit attempt at all in this throughout the 6-month follow-up, any 24-hour quit attempt, whether they were quit at 1 month, quit at 3 months, quit at 6 months, or what we call floating abstinence, whether they ever achieved 7 days in a row of not smoking. Now, the first thing you're going to notice is the numbers are low. Yep. Remember I said efficacy is going to drop. Okay? Efficacy is going to drop, but for every outcome here, they were either numerically or in some cases statistically superior for those who received the 2-week supply of nicotine replacement therapy, including 6-month quit rates. So a simple 2-week provision of NRT yielded an effect 6 months later. Amazing. Okay? I mean, I don't mind saying I was a little surprised. Yes, 12 versus 8. That's you could focus on that and say, wait a second here, 12%. This was a 30-second intervention. 30 seconds, ish. Now, what was cool about this study is that we brought in what we call all comers. Remember what I said at the outset? We're not just treating people who say, yeah, I want to quit smoking, sign me up. If we only help those people, we will have done limited good. But if we can also help the people who say at the outset, you know what, I don't really want to quit smoking. So we recruited those folks too, and now that allows us to do a sensitivity analysis or a subgroup analysis. Okay, so again, any quit attempt, any 24-hour quit attempt, whether you were quit at 6 months or whether you ever achieved 7 days in a row of non-smoking. You see the NRT group compared to this standard care group, and you see the low motivation group and the high motivation group. These are people at their motivation status at baseline. So the first thing you're going to say is the absolute quit rates are higher in the high motivation group. Absolutely true. These are people who want to quit smoking, and they were given a tool to do so. You would expect the quit rates to be higher in that group. Okay? Now, but the second thing that I really want to draw your attention to is those highlighted columns. The treatment effect, okay, which in this case is the adjusted odds ratio. Let's not get into the statistics of it, but the treatment effect, which is that yellow column, was the same or higher among people who told us at the outset, I don't want to quit smoking. Okay, so we didn't just help people who told us they want, and I was really, really pleased with this. I mean, really quite pleased. Okay, I could show you an hour's worth of outcomes, and where you can look at our many of our outcomes papers. I don't have the time to do so because I do want to hear from the panel and from your questions, but I'm just going to sort of sum it up briefly, if I can, that NRT sampling will never be a panacea for smoking cessation, but it can outperform standard care, which is practitioner advice. It offers strong potential for reach in busy clinical practices. It took minutes, I said seconds, and I do think it was as few as 30 seconds, maybe a couple minutes. Few minutes to deliver. It was behavioral. It was concrete. Okay? You're giving something out. You're a present giver. Okay? And it's immediately actionable. Go home and use that patch that day. Okay? Now, I'm not here to diminish brief advice or motivational interviewing, am I? But, those are verbal based, and, I think they stand in contrast to, it may leave both provider and patient frustrated, because now what? Our intervention took minimal instructions. When I said the word sampling and when I said the word dental baggie, you knew exactly what I was talking about, and it can be given to a broad spectrum of smokers. So it's scalable. Okay, it's pragmatic, and it's really cheap. Okay, now you're not paying for the intervention, Sandra is, but it's pretty cheap, and it takes just a minute or so to deliver, so it's not a lot of time on your part. And this was a shocker to me. We did a cost effectiveness analysis on that same clinical trial. This intervention was cost savings. So when you hear phrases like cost effective, that's when the benefits outweigh the costs. This was actually saving healthcare costs down the road. Okay, we had a health economist write this paper up, and he, through umpteen different ways, rigorously showed that we're saving healthcare expenditures down the road. It's saving cost. Okay. All right, remember what I said about health impact equals efficacy times reach. So this is a little bit of a complicated slide, but I'll walk you through it. So think about current evidence, and these numbers are true. Okay, 28% of people who smoke will make a quit attempt in a given 6-month period. Okay, 0.28. 28% will make a quit attempt in a 6-month period. 25% will use an evidence-based treatment method, and only 25% of those are going to be successful. Let's face it, our treatments are not that great, but they're better than nothing. So if you multiply all that out, you get a population impact of 1.8. Now, medication sampling. We're getting more people to try, 50%. We're getting more people to use an evidence-based method, 65%. Look at our quit rate, it's lower. 10%. 10%, okay? But when you multiply that out, we're getting more people to try, 3.25% quit rate overall. So don't be fooled by low numbers. If I had to reduce this study down to one line, I would say it's this. It's about getting more smokers to use better treatments sooner. That's the significance. All right, now hopefully these don't apply to this audience, but in case they do, let's talk about some issues that might come up, some concerns. And actually, the panel will do a better job on this than I will. But this idea of I've tried, it doesn't do any good. I can't help. Okay. Effective clinical interventions do exist, and if you do nothing, I almost guarantee you nothing's going to happen as an outcome. And interventions need not to be, even small interventions can have a measurable effect later on, as we've seen tonight. I don't want to ruin my relationships with my patients. I don't want to be somebody, a nag, okay? Well, nobody wants to be the nag, I get it. But guess what? Patient satisfaction increases when providers ask and advise about quitting, and when they provide helpful solutions towards quitting, okay? So if I were to say, if you were just, ask and advise, you need to quit smoking, that might run towards nagging. But if you say, the best thing that you can do for your health is to quit smoking, and guess what? Here's an option that you might consider. Just give it a whirl, okay? Give it a try. Not nagging, it's providing helpful. Patient satisfaction goes up. This isn't my job. I would say it is, and hopefully I don't need to convince you of that, as the American Dental Association provides strong recommendations to do so. Not enough time. Your time is precious and it's limited. And if I were to pitch something here that's long-winded, you would shut the door in my face. But this can be brief, and brief touch can have a measurable effect downstream. Don't dismiss that. Okay, so the rest of this hour, this is enough of me talking. The rest of this hour is really about how we can make this work for you. If you have questions about my particular study or any of the work that I've done, you can reach me at that email down below. But really, the rest of this is about you. Sandra, I don't know if you wanted me to keep these slides up or take them down or what.
No, you can take them. We will kick it off to any questions that you want to ask or anything the panel wants to raise themselves. So we'll start by, can you tell me about your experiences with the FreSH study? Anybody who wants to start? Go ahead, Dr. Richardson.
Okay, I can start. I mean, they've been positive. The more I ask, I can tell some people are very cynical in nature, and they're just, I've tried and I wasn't able to get through it. I've tried it before. I can't do it. But I think just being honest with them, and I do use, you're also helping me because for some reasons or different reasons, dentists don't talk about smoking cessation as much as they should, knowing that oral health and smoking, they don't go together. So a lot of patients have said, well, if it helps you, I'll give it a try. And I think, as long as I can kind of get them to take the samples and ask them to just try. Most of them are like, oh, I've always wanted to try this. I couldn't afford it, or I've always wanted to try it. I just don't do it, and explaining that it works. But sometimes if they think they're helping me talk about quitting more often in the practice, and other dentists, they're more willing to do it.
I think that's a great point. And they're helping other people too. Other people like them.
Yes.
Sometimes can help too. Dr. Romano, tell us about your experiences in the FreSH study.
So this has been very eye-opening for me. I've participated in several studies before, and in this study, in other prior studies, I don't think I have had one person who didn't want to participate. In this study, I have to kind of strong arm and persuade people to participate in the study. The patients, first of all, there's not a lot of patients in my practice who smoke. The ones who do smoke, they kind of come in three varieties. One is they're closet smokers and they don't want to be found out. And when you have to ask them questions about putting their telephone number and address down, they just say, no way, I'm not going to participate, because they tell me even their spouses or their kids don't know that they smoke and they don't want to have anything to do with that. There's another group that feels, okay, I know I smoke, I know it's bad for me, but I have no intentions of quitting, and so I'm not going to participate. And then the final group is a small group that will participate and really has an interest in in stopping smoking. Now, I don't harass them in a way to say that I want you to quit smoking. I just simply say, if you're interested in it, this may help you. We can help you do this. Other problem I'm finding is that to work on the iPad, it takes much longer than we thought. And the people who are participating are the older people in my practice, and they are not computer savvy. So my assistants have to spend more time with them on the iPad, and it backs me up in what I'm doing clinically. And we can't stop and come back to it, because if you stop, it logs out, you have to start all over again. It would be better if we could log out and pick up where we left off to complete that process of getting them all set up into the study itself. My staff will tell you that the word they came up with is persuade. I have two great assistants, and they present it first, and every time they get shut down and turned down about smoking or participating in the study, and then I come in and I have to persuade them. I don't blackmail them, but I have to persuade them to participate. And the best way I can do that is to let them know that by participating, they're helping society as a whole. We're not interested necessarily in them specifically, but in everybody. We're trying to find a way to reach people, to help people, those people who do want to quit smoking, to give them assistance to do it that way.
Okay. Great, thank you. Dr. Durand, how has it been for you?
It's been great for me. Early on, and I've taken part in a number of other network studies as well. And through a couple of them, it was really crucial that a couple of my hygienists became able. They did the CITI training, the human subjects training, and so in all honesty, my hygienists have enrolled every one of our patients in this study so far, which has been wonderful. They are the ones that have this relationship with people. They're the ones that are, before a patient comes in, they're tracking their smoking status. We've got our, online medical history. And so they're already kind of picking out who they might want to ask to be in the study. I think they have their own way with patients in terms of encouraging them to tweak their home care routines with regards to brushing, flossing, reducing caries risk and all that kind of stuff. And so this kind of I think has gone really hand in hand with that type of a relationship they have with them. And so they've done a great job enrolling patients. So it's been really slick.
Great. And Dr. Bravick, am I saying that right? Oh.
The study's been going very well for me as well. I would agree, it does take longer than anticipated. One of the things that I have done to help my patients is I actually help them fill it out. It goes a little bit quicker than just handing them the iPad. The other thing to increase enrollment, we also have our receptionist asking the patients as they come in about smoking, which has opened up a whole another, avenue to improve communication.
Great. And then do you get them started right there in the waiting room?
Yes, she'll start talking to them, and then we have a separate room, an office where we have them review the consent, and then I'll go in and start talking to them about it. So our system works slick with her starting the whole conversation, because they can be starting to fit. If I'm not helping them, then they can be starting to fill the questions out before I bring, or the assistant brings them back to the operatory.
Right. So some of you have touched on some challenges. I'm interested in what challenges you faced, and if you haven't already mentioned how you've overcome them.
I'll just say that, one of the things is time. And so I think we've all been there in any study we've been in and have kind of chosen to maybe put a pin in this until we see that person next time and try to be sure that we can catch them next time to do the study. Or if we know they're going to be coming back for some other visit for restorative work after their hygiene visit, we might try to catch them then before they're. So, we may have identified the people, but knowing that we may not have time if we've got another patient coming in right after the fact, that the timing might not work out. Or we've got a nice kind of, secondary waiting area, that kind of our kid room, so to speak. And so we've oftentimes just sent them in there with the iPad, and then one of the hygienists has kind of checked on them as they're filling it out. So the 3 hygienists are also kind of working together in some ways to try to be sure that individual is kind of finishing up the iPad work before they go. But it's taken a little bit of time, yeah.
I just want to make a comment if I could. So, I made a big deal about this being a short, brief intervention. I kept saying 30 seconds. I get it that in the context of the clinical trial where people have to be consented and there's baseline questionnaires and things like that, that process is longer. It was the same for my study in primary care. But the solutions that we're hearing right now are the exact solutions that we heard when I did my study some years ago. And what I also learned, and I just would say here, is that no one solution will work for everybody. I mean, people will find their own little idiographic techniques in the children's room or a waiting area or something like that. I get it. I mean, you don't want to have people sitting in the chair for a half hour or much longer than they need to. But I do think there's creative solutions to get around that. Science takes, a clinical trial, you can't do it without a consent form.
I do have a question. I wonder if anyone else has noticed that more people are vaping than using the combustible cigarettes, so they don't qualify for the study.
Yeah, so we have heard a lot about vaping, and certainly vaping is on the rise, particularly amongst people, under 30, under 25.
Absolutely.
So it depends on your practice and how old your practice is. Dr. Romano said it's the older people who are still smoking.
Yes.
Yeah, so we don't know yet about how vaping affects oral health. There needs to be more work in that area. I'm hoping to do more work in that area, but we don't yet know. And so it's just
Okay.
for this study, it's not really the focus. That being said, a lot of people are vaping and smoking at the same time.
Mm-hmm.
And those people are absolutely eligible for the study.
Okay.
Good point.
Other challenges people found?
I would agree with both of them. It's mostly just the time, and then, I mean, it seems to go in spurts with me with people that do smoke. There does seem to be more vaping than smoking, but it seems like all of a sudden in 1 week I'll have 5 smokers where they ask about it and they don't have it. Like another, people are not smoking, which is great, but
So how are you managing the time, Dr. Richardson?
We usually have a room set aside, and we'll check on them if it's getting to be long. So just kind of having a separate area where if we start the study, then we can have someone check on them.
So Dr. Romano, you talked about the closeted smokers. I haven't heard. I didn't think about that. I mean, definitely I know that there's people who are closeted smokers. I haven't thought about them. But the people who don't want to, go ahead.
There's a lot of them.
Yeah.
I was surprised. People tell me their kids don't even know they smoke. Their spouses don't know they smoke.
I think there's a lot of stigma, right? I mean, and people don't want to sort of fess up and say that's me because, you're considered second-class citizens, unfortunately, in some regards. So, I think if we sort of meet those folks with understanding and say, hey, I get it. You're this is something you're not wanting to sort of put out there. I don't know. It just goes back to, I come back to meet smokers where they're at.
I think that I think that if this was part of our practice and we were introducing smoking cessation or potential smoking cessation to our patients, it wouldn't be an issue. The fact that they have to enroll in the study is what's causing the problem. Because when you enroll in the study, then you got to put your phone number down, you got to put your name down. That's what they don't like. If you can somehow make it more private, so that they can feel that they're not going to be exposed, and you're going to get more participation.
Yeah, I will say a couple of things for that. We named our study Free Samples for Health. We did not name our study Quit Smoking. We don't have a quit smoking sign on any of our materials. We never say we're calling from the smoking study. We always say we're calling from the FreSH study. The questionnaires that go to their email say that they're from the FreSH study, and it's only if you click on the link that there's questions about smoking, but there's questions about other things too. I get it that you might be bringing home nicotine replacement therapy, although I don't know where they hide their cigarettes. Maybe they could hide it there in their car or wherever, So I would assure them that never is someone going to call and say, I'm calling from the smoking study, and never are they going to get an email that says I'm calling, we're from the smoking study. It's always going to say FreSH. It's going to say Free Samples for Health. Half the people get toothbrushes. So that's one thing we did really intentionally. We hope that we are transforming you as practitioners who now feel comfortable talking about smoking with your patients, even if they don't enroll in the FreSH study. We hope that you'll feel comfortable having these conversations and telling people about resources and knowing how to refer to the quit line even after we leave.
Go ahead.
Sorry,
I was just going to chime in there. I know Dr. Romano mentioned that he's kind of having to coerce or kind of prod people to do it. And I guess I've been kind of hardened. I feel like it's one of those things where you fear you're going to offend somebody, or call out some behavior, or make it feel like you're passing judgment on them or something like that. But like Dr. Carpenter pointed out, people want to be asked, and I think previous network studies have shown that too, that to not ask is almost more bothersome to patients than asking. I mean, they know they smoke, so we should be asking them that, and I think that's helped to reinforce that for me personally too.
And because of the stigma, they don't bring it up sometimes, depending on the person, they might not bring it up. And so just giving them a space. And I think that's what's so brilliant about this, like giving them a gift, right? Like, I'm not asking because I'm judging you, I'm asking because I have something to give you, it changes the tenor of the conversation.
Go ahead.
I so agree with Dr. Carpenter too. It's so much about meeting them where they're at and understanding. A lot of patients feel bad. They tried quitting in the past, it hasn't worked, they feel shame. And so just listening to them and being there for support and, just encouraging again that, quitting is the best thing for their health. Really, I think in the end is going to make a difference.
Yeah, I agree. The other thing I just quickly add, I know I'm preaching to the choir here, but all research studies have confidential data. Sandra has very strong precautions for safety of data. Names are not attached to responses, those types of things. Anybody's phone number and address is all kept in very secure ways that are really inaccessible to anybody outside the study. So I understand there's reticence to sort of give out personal information. I'm sort of in the same way. But I think we that's an opportunity to sort of educate folks about science in general. This studies are confidential. Data are confidential. They're overseen by ethics boards, etc. I mean, there's lots of precautions in place.
I want to say something about the people who don't want to quit. A couple of things. I think Dr. Carpenter gave a really clear rationale that this is for everyone. And so I think working on that pitch for folks to say, like, you can use these samples however you want. Like, if you're going to go on an airplane, if you're going to sit in a movie theater, if you're going to be in a situation where you can't smoke, these might come in handy. Or you might not be ready to quit now, but sometime in the future they might come in handy. Or if you just never tried them before and just want to see what they're like in case someday you might want to use them. And that you I think a lot of times when people sign up for studies, they think somebody is going to make them quit, or they're making a promise to someone to quit. So if you could take one thing away from this meeting, I would say, like, this is a study for people who smoke on how to improve their oral health. It is not a study for people who want to quit smoking. We're testing whether or not just giving samples is going to change, people's motivation to quit, and maybe it won't, and that's fine too. Like, you're not going to ruin our data. That's the point of the study.
It's very well said.
Find out. Go ahead.
My observation, my personal opinion is that it's a wonderful thing to have in your practice to do, and I think broad basing, hitting everybody, is going to have an effect on people. The challenge I'm having is the study. It's not introducing the thought of coming with some way to suggest they stop smoking. It's the study. It's the details of the study which are the challenge of the project.
Sure. And we did a pilot before we did this study, and I said over and over again, not the pilot Dr. Richardson wasn't, she was perfect, and I have no complaints, but the study before the study that Dr. Richardson was in the pilot of, we did the intervention ourselves. We just hung out at a dental practice, the researchers, and we had a receptionist screening people for smoking. And no matter what we did, they called it the quit smoking study. So just really being careful about the language your staff uses and how you present it to patients, and just really saying explicitly, you do not have to quit, because patients mix up confidence and importance in quitting. So they will want to quit, but not think they can. And then they will reject, they will tell you that they don't want to quit because they don't think they can. So one of the things that nicotine replacement therapy does, and giving people medications does, is give them some confidence and increase in self-efficacy that might make them feel like maybe it's possible. But you have to get past that point of no first. Okay, so here are some things that have come up. So a lot of you have mentioned having a hard time finding patients who smoke. We heard the receptionist, just starting right at the receptionist is one way. We heard getting your hygienist on board to check everybody as part of a health check as another way. We had one of our hygienists who's actually finished the study now. She recruited so quickly, she was pre-screening all the charts. And I know all of this takes time, but these are just ideas. She was pre-screening all of the charts and then putting out a lovely display of sample materials for people to look at, to just try to kind of increase interest in the study. Anything else you've tried to help identify people who smoke?
It is a question that we ask on our medical history. So pre-screening, like the charts, is a good tip to use as well.
Yeah, I know it's a common thing to put in your medical history, and probably is or should be standard. Any other tips people have on getting people? Okay, then the next thing we've heard is that for this study, people are saying no, which is unusual for a PBRN study. So does anyone have tips on how to pitch it? We heard from Dr. Richardson saying, you would really be helping me. And I don't know if you meant helping you because you don't have to do as much dental work, or helping you to meet your numbers in the study. I'm not sure which. We heard from Dr. Romano helping other people, helping the greater society. Has anybody else come up with a good pitch?
We're in the sample wing, and so I think one of the things we're saying is that, hey, you can try these things for free. You're getting these samples. Now I haven't consented somebody in a long time on the study, but I can't remember if they've got to agree to be in the study before they find out whether they get a toothbrush or the stuff, right? Or
they have to agree before they know, because if they just really want a toothbrush, we don't want somebody to sign up just and decline for other reasons. But saying you get to give you something that's a pretty high value, like a $70 value or something.
make a quick comment. So one of the improvements that Sandra did for this study that we did not have for mine is the control group gets something. So in my control group, they got brochures, and what a deflating thing that could have been. It was deflating, and we heard the same types of stories. Sandra wisely rectified that for this study, and everybody gets something. Everybody gets something. Now, maybe there's a hook on that. I don't know.
Yeah, so if I were to make a pitch, if I were to give any tips about the pitch, it would be to really introduce it as a study for people who smoke. You don't have to quit. Just really getting that up front. Just to let people know.
And the messaging, like what? And once you're in the study, the messaging it hits you over the head with that. I mean, the brochures that you get, the messaging that's attached with the nicotine replacement products, will really reinforce that. Hey, look, folks, if you don't want to quit, you don't want to quit. Just get, someone said use it on the airplane and things like that. There's lots of ways that you can try it without a firm commitment to quitting. I do think there's a strong, when people say a smoking study, they're going to think it's you have to quit smoking study. And that's what Sandra's saying. That's the sort of the image that we've got to sort of circumvent. Somebody has a question in the...
No, we got something in the chat. So we got a dental hygienist. One of the benefits of the FreSH study, the dental hygienists are here. They are in their element as oral health educators, and they are recruiting as practitioners here in the study. So we love that. And she says if she notices signs of smoking on people's teeth, like staining or periodontal disease, she will ask them if they smoke, even if it's not in their medical history, and use that as a foray into smoking cessation conversations. Great point for now and the future.
I'd like to know, I have a question. Are the people in the study that I'm participating, I don't have the nicotine replacement therapy. All I have is the toothbrushes. The people who have the nicotine replacement therapy, are they having more success recruiting patients than those?
They're not supposed to tell people that they have the nicotine replacement therapy. But I don't know. I'm
just wondering right, we don't tell people we have them until they have to signed up for it, but is there a discrepancy there? Or is it sustained?
Is there any way of measuring the implementation of the study in terms of like our own internal biases? If we think, right, I get to give them NRT versus, I get to give them a toothbrush. Are you able to measure us in terms of how well we're delivering the message?
They're doing better. Yeah.
Say that again, Sandra. What?
We could look at that. We haven't, but we could. Okay, so we had in the Q&A, we had a participant that informed us she was trying other cessation methods and was disqualified. We're struggling with finding patients that smoke cigarettes. We definitely have vaping and herbal smokers. We also had a patient who declined when they found out they would have to answer follow-up surveys on their own without clinical involvement to help remind them. So we do remind, so for that one, we remind them many, many times. And if they don't fill out the surveys on their own, we call them and we do them over the phone. So they will have reminders. They won't have to figure that out on their own. And then Sarah, our note coordinator, says, we have learned that some state quit lines will also provide NRT samples to patients who are referred to the quit line. Yeah.
And participants get money, right?
And they get money, not a ton of money, but they do get $20 per survey to do the surveys. Yeah, so people using other smoking cessation medications are disqualified because they're already using a medication to quit. But that's right at the moment, so they can come back. If you come back and see them again and they are off that medication, they can certainly try again. You can thank the NIH reviewers for that exclusion criteria. Other questions for the panel while we have them? Or anything you want to bring up and discuss, or anything you have learned is useful that you want to share with others?
I can't speak highly enough about having the hygienist involved. That's just been such a huge help for me, not only in this study but other studies as well. You know, when we did dentin hypersensitivity and other studies that had kind of a hygiene lens in some ways as well, that has really been helpful, and I think it helps them buy into kind of thinking outside of our own little four walls as well.
Yeah, Dr. Lewis was part of the pilot too with Dr. Richardson, and his hygienists were finding people on days he wasn't even working and then bringing them back the next day to sign up for the study. Yeah, I think this is really in the hygiene space. Dental hygienists get a lot more training about tobacco cessation in their training programs and really have a health education lens. And they also spend a lot of time with their patients versus dentists if things are going well. Okay, in the chat, we had a participant that informed us she was trying other cessation. Okay, no, sorry. Oh, okay.
In the study, when you told me that Dr. Lewis I thought I was doing pretty good, but then you told me he had so many more patients than I did. That was motivating to me because I'm like, wait a minute.
Yeah, competition.
Yeah, if anybody wants some performance feedback, we know how all of you are doing at all times per week. We watch you very closely. What was I going to say about that? Lost it now.
So Sandra,
if we have like 1 minute, is anybody reading the newsletters? Are those helpful? Should we stop doing that? Should we do something differently? I'm getting blank stares.
No, I like them.
Okay.
Yeah.
I agree. I read them.
Okay. Good to know.
Me too. I read them.
Okay, great. Well, you'll see a recap of this meeting in the newsletter next week. Well, thank you all for taking time out of your evening for the study, and also thank you for being part of the study. You're really contributing to science and making my dreams come true, and I look forward to maybe having more of these and also sharing the results when they come out.
Thank you so much, everybody.
Yeah.
Everybody, and thanks
great.
especially to the panel. Oh, go ahead.
I was just gonna say, you know, the ability to hand out samples for somebody that, you know, Dr. Romano talked about closeted smokers or people that are just not ready to quit, but you can give them something. It would just be great if, as providers, you know, in whatever state you're in, if we could work directly with the quit line to just have some stock supply of NRT materials that we can just hand out, you know. And I'll periodically do a, you know, Chantix prescription, but it's not very common, you know. But I just wish it was much more easy for us to just be like, hey, why don't you try this, you know?
Yeah, so that's why we're doing the work, Dr. Durand, is because they're not going to do it unless we have science that supports it.
Yeah, right. So thanks for the study. It's great.
Thank you all for participating.
Thank you.
And feel free to reach out anytime if you ever have any. Oh, wait, everybody wait, hold on. I have to show you the continuing education link because you do get CE credits for this. So let me just share that real quick. Okay, so your CE credits, you get one CE credit. That CE credit will be mailed. It will pop up immediately after you leave the Zoom, and the CE credit will be emailed to you. Okay? All right, thanks everybody. Have a great night.
Good night.
Bye.
Thank you.
Bye-bye. Thank you.